Hey, happy Veterans Day, everyone. I was actually at the Pentagon a couple weeks ago, which is actually really neat. And if you've ever been there, it's like a city. It's like a city of super well-dressed and standing super tall and erect men and women who just looked like, thank God they take care of us. And so if anyone here is a veteran, please know that we appreciate everything you've done. But you don't get the day off. You're going to work very hard today. It's a long, tough day. So in case anyone didn't understand any of the past three talks, thank you. I will summarize them for you. One, Dr. Anthony taught me, stop checking labs. Number one. Number two, Dr. Tricolinas taught me, you should never listen to a medical oncologist who talks about surgery. That could be two, yeah. And number three, I also learned that there are multiple people I need to discipline in my tumor board to teach them what to do. So those are the things I learned. Okay, so my topic for today is biomarkers. And basically, those are all the labs that people send off for you all the time, right? You go, and if anyone has met Bethany at at our table, you know that she goes and she sticks you all the time and draws all these bloods. And you know, I just wait until twilight opens up in my clinic because that's really where it needs to be done. But no one got that? Okay, I tried. Twilight? No, we don't have any teenage girls in this audience today. Anyway, so we do a lot of vampire work, and my question always is that if we vampirize you all day long and suck out all your blood, maybe that's the real reason you're anemic. But, you know, it is an important thing, and it's kind of almost traditional. And actually, the thing that Dr. Anthony said was actually very profound, because really the question is, what does that information mean? What do I do for that, right? So that's the question. So let's talk about that. And everything you've kind of heard so far has been very technical. I'm not going to be very technical, okay? I mean, it is about how you appreciate the things that we do so you can understand why we do it, okay? Does that make sense? So it's a practical approach to this. So I always tell people because people come to me all the time, right? They're like, what do I do? What do I do? This is what you should do, right? You should always go see a neuroendocrine specialist, period, right? I'm not saying it has to be me, I'm not saying it has to be Dr. Anthony, but you should see someone who has expertise in this because it is different. It is different, period. Okay, there's no negotiating that. So you need to see someone who sees this 10 times a day, not 10 times a year, as Dr. Tricolinas mentioned, a day. And that's kind of how it works, right? And then people always ask me too, well, what's the first thing I should do, right? You've heard many things, somatostatin analogs, medicines. That is not true, right? What is the first thing everyone should do for their treatment plan, right? It should always be to cut it out. That's right. I show this slide every time. What is the second thing everyone should do? That's right. Think about it again, if I can get it right. And finally, the third line of therapy should always be to yes. This group is teachable, Dr. Anthony. Teachable. What's That's right, exactly right. Okay, so I'm teasing, and this afternoon I'll show you why this is actually very, very important. But it is the only opportunity that we really have to, at best, to cure you, and probably much better to help you, right? So my goal today is to talk a little bit about what a biomarker is, right? I know you guys know it's a lab test, it's a, whatever it is, but there's something that we want to do with it. We'll talk about the neuroendocrine biomarkers. I'll talk to you a little bit about how we kind of think of biomarkers, and honestly, biomarkers were a very rich field of research and probably building of careers, and I'm not really sure it was so helpful to so many people. But ultimately, what does that mean, right? And I'll try to give you a couple little pearls so you can understand why we do them and how we decide them, okay? So I tell people all the time, we have certain tools, right? As a physician, if you really break this down. I have an office visit in which I can sit and I can talk to you and I can listen to what you have to say, right? It's by far the most important thing, but it's kind of like the sense of hearing, right? So I listen to you, I hear what you have to say. Then after we're done talking, then we'll draw your blood, and those are the labs that we send off, and that's a little bit like the sense of smell, right? So I'm kind of sensing what chemicals are coming from your disease. Then we have imaging, in which I can actually look and see. That might be a CAT scan or an MRI. Then there's the nuclear imaging, which I can see even better, right? So you take the filters off of your glasses, and you can really see what's happening. And then, of course, there's endoscopy, and as we just learned, of course, there's pathology, right? So if you kind of think about it, these are the senses that I have as a medical professional to figure out what you have and decide what to do, right? So let's do a little definitional work, okay? So what is a tumor marker? So this is from the National Cancer Institute. They say a tumor marker is anything present in or produced by cancer cells or other cells of the body in response to cancer or certain benign, non-cancerous conditions that provides information about a cancer, such as how aggressive it is, what kind of treatment it may respond to, or whether it is responding to treatment. So basically it's like, well, is there a blood test that gives us some information to help us decide what to do? Okay, that's how it breaks down. And it's very classic. There are many, many biomarkers we use for different kinds of cancer, right? Some of them are for screening. For example, prostate-specific antigen for prostate cancer is a very common test that we as men get, right? Unfortunately, we are discovering, that screening with the PSA may not be the best way to follow and to find prostate cancer. So we're thinking about that all over again. We have other markers such as this CEA, which is about colon cancer. We have more esoteric ones called CA19-9 for pancreas cancer and biliary cancer, CA125 for ovarian cancer, and CA2729 for breast cancer. Okay, so those are a bunch of letters, a bunch of numbers, which probably don't mean a whole lot. But for us, you have to think about it. Before we had good CT scans or really great imaging, right? Before I could see very well, all we could do was smell. So you could draw a little bit of blood, you could test the blood, and you could determine if there was some correlation between that blood test and the cancer that you had, right? So a little bit of this is historic. The imaging is very good, but it's definitely more expensive. It's obviously more invasive. There's a lot more to do, right? So the blood test is easy, and it's just what we do. It's not that hard. But then interpreting it actually becomes very difficult, I would imagine. So what are the neuroendocrine biomarkers, right, specific to the people in this room, right? Well, the most obvious and the easiest ones are always the hormones, right? So did anyone know why we call it neuroendocrine? Neuro because they're smart cells, they control things, right? And endocrine because they function through hormones. The way they control things is by secreting hormones. Right? And so when you secrete the hormone, that's the easiest thing to look at, right? One would assume the more cancer you have, the more hormone you have. That is not 100% true, but it is something that's pretty relative. So if you say, for example, your tumor comes from the small intestine, it's metastatic, and it secretes serotonin, right? Well, serotonin is obviously, we usually think of as a happy hormone, right? You take a little Prozac, everyone feels a little bit better. It was in your breakfast this morning, so hopefully it'll get you through the day. But when it doesn't work very well, it can make you flushed, right? You know that. It can give you some pretty bad diarrhea. It can make you hot through the day, right? See the fans going here? So it can have multiple symptoms which can torture you as well, too. So by listening to you and hearing your symptoms, which is probably just as good, I can then corroborate that by then drawing the bloods and seeing if they match up, right? And that's fine. And so 5-HIAA, called 5-hydroxyindoleacetic acid, is just a breakdown product of serotonin. It was just easier to measure than serotonin. You can do it in the urine, you can do it in the blood now, so if anyone's interested in the blood test, you can certainly go see our colleagues at InterScience Institute who have the special blood test for it. But all the hormones are markers, right? So if you have elevated gastrin, it's the acid producing hormone. If you have elevated insulin or any of the derivatives of insulin, right? If you have glucagon, a much more rare kind of cancer, VIP, those things can be markers. But really, let's be honest. If you told me I'm going to the bathroom 15 to 20 times a day, I probably don't need to measure a biomarker, right? Because the biomarker's you. Is you tell me what's going on. But we do it just to kind of correlate the two. It's things we can measure. But then we have these other biomarkers as well, which are not necessarily the actually active hormone that is causing the symptoms. So the classic one, and I know everyone in this room has had one drawn, right, is the Chromagran and A, right? Chromagran and A. And Chromagran and A was a wonderful marker, honestly, probably, when Dr. Anthony was getting his career started, right? So that's a long time ago. A long time ago. But it was a very useful test because we didn't really have that much. CT scans were more difficult to get. They were probably more difficult to interpret. So the biomarker was very, very important. And in fact, my mentor, his name is Dr. Oberg from Sweden, was one of the pioneers with the Chromagran test, and it actually was very good for the time. But did you know there's a Chromagran and B? Anyone have a Chromagran and B ever tested? Yeah, we never talk about that. Well, luckily, there's been some evolution to this. The second generation of Chromagran has come out, so it's called Pancreastatin. It's a breakdown product of Chromagran, seems to be a little bit better. There's another test that's been championed by our colleagues, Dr. Waltering in New Orleans, called Neuroendocrine and A, which also may give us a sense of how things behave. There's a much older marker called neuron-specific enolase, right? Neuron, because it's smart. Specific enolase, which seem to also correlate with the disease. And then depending on the type of neuroendocrine you have, for example, if it comes from the pancreas, maybe pancreatic polypeptide is your marker. It may not be the one that's causing your symptoms, but it may be something we can follow to give a sense of it. And there are even more esoteric kind of fancy tests, such as the NET test. You've all heard of the NET test from the Ren laboratories, where they look at your micro RNAs. So it does get quite fancy, but sometimes it can be hard to figure out. For example, Chromagran and A has almost become a very useless test because so many people take some kind of proton pump inhibitor. If you take a proton pump inhibitor, it automatically makes your Chromagran and A level go up, whether you have neuroendocrine or not. And a lot of people take it, as we heard, for other kinds of diseases, such as Zollinger-Ellison syndrome. Well, guess what? Now, all of a sudden, that lab value is a little less helpful, right? And look at this NET test, right? This NET test, I challenge any of you to interpret all those things that are coming off on that little graph there. It can be very, very complicated, too. So now you're like, wow, we have these blood tests, we have these microarray tests. It does get fancier and fancier, but what does it mean for me, right? Well, let's talk about Chromagran for 1 second so you all understand it. So Chromagran A is kind of the workhorse for us. It's like the PSA for prostate cancer. It does maybe help you make the diagnosis. It may reflect the tumor mass, and as it changes, it may kind of give you a sense of whether your disease is changing or not. There's no question the scan is better, period, okay? But the Chromagran is easy, everyone does it. It's not perfect. It is not perfect. It is thrown off by the proton pump inhibitors. It is thrown off by people who have a different disease called chronic atrophic gastritis, and it can certainly be caused when people have kidney problems. So it's not great. In fact, I have almost abandoned using Chromagran. The biggest problem with Chromagran is that there are like 5 or 6 or 7 different labs that run it, and you may get it done at one lab one time, and a second lab the second time, and a third lab the third time, depending on whose contract your doctor is with or which doctor you see. So these numbers may change, and you'd be like, wow, what happened to my numbers? And it turns out it was just a different laboratory. Okay, so always keep that in mind. Then there's the 5-hydroxyindoleacetic acid. I'm sure a lot of you had this test. This is the urine test, right? You had this before? Little brown jug. You have to pee into it, collect it for 24 hours. Always next to the apple juice. Hard to figure out sometimes, right? So, and the other problem too is that you have to watch what you eat, because if you take a whole bunch of the happy foods, right? Serotonin, happy hormone, chocolate, walnuts, bananas, avocados, they will increase your hormone levels because it comes from the food itself. So you have to avoid these things in order to make the test meaningful. But how many of you have had a doctor order a urinary 5-HI like every 3 months, right? When you don't really understand the test, you just keep ordering the test, and it happens over and over again. When was the last time you ordered a 5-HI every 3 months? Never, right? So the question is, what value is it? Well, it turns out that people who have an elevated 5-HIAA actually probably have a little bit higher risk of developing this carcinoid heart disease, right? Because their hormones are very high. So those are the things that we kind of use to watch out for them. But again, the serum test is very helpful. It is a way to kind of follow things. And it's a very tried and true test. And of course, there's the blood test from the InterScience Institute. All right. So what does it mean to the doctor? What does it mean to the doctor? Well, it turns out that the labs can be complicated, and I am sure we only measure one of probably 7,000 different hormones and biomarkers we could measure, right? Did you know that there are actually, despite the fact we only talk about Chromagran and A, there are actually like 7 or maybe 70 different types of chromagranins? Okay, so we measure one. Right? That's not great. And of course, like I told you, we all measure Chromagran and A, and no one even knew there was a Chromagran and B. But Chromagran and B also can be used as a biomarker, and it can also correlate with the different types of neuroendocrine tumors. That's not the point of the slide. The point of the slide is look at where the dots fall. It's a huge, huge range. This is a logarithmic scale. So some people fall in the tens, some people fall in the hundreds, some people fall in the tens of thousands. So what does that mean for any one individual person, right? That becomes more challenging to understand. Again, it is a historic test. It does work okay, and there are benefits to it. But interpreting it for one particular test may be difficult for any one particular individual, all right? So, but it is okay. So this is a historic slide I got from Dr. Oberg. He shared it with me, and he said, look, when you have a lot of tumors, so like greater than 5 liver metastases, people may have higher Chromagran As. And if you have less metastases, and if you have even no liver metastases, then you may have even lower. Except for the fact, if you take Nexium, Prilosec, Protonix, or anything, it will automatically raise the value. So now it becomes a little bit more difficult to interpret. All right, so the newer test is called Pancreastatin. Okay, Pancreastatin is a hormone. It actually does have effects, but it's a marker that we can use that will help us determine how the disease is working and functioning. So our colleagues at the University of Iowa have recently tested. They are great, great champions of this test. And they found that if you could do surgery and get that pancreastatin value way, way down after surgery, then the patient has a much better outcome. Now, that's probably not magical if you think about it, right? So if I do a better operation, the patient will probably do better. I mean, that doesn't sound like rocket science, but it certainly can be validated with the blood tests, right? So that's helpful. Is it helpful enough? I don't know. We can decide that, but it's helpful. And then you can do lots and lots and lots of research studies on things, right? So for example, the REN-NET test, which is very complicated, don't get me wrong, more complicated than I can probably explain to you. But what it is, there's a lot of research about it. And sometimes when the studies just keep coming and coming and coming and coming, maybe it's hard to figure out exactly how that test works, right? And so I'm guilty of this. This last one is the one that I worked with them because I really, really, really want it to work. I just couldn't quite figure out how to make it work. And so that's what's been a challenge. So there are definitely smarter people who will help me learn and figure this out. But it is these tests can be difficult to interpret and to apply to any individual person, all right? I hope that all makes kind of sense. So the important thing for you all to understand is that no blood test is better than a scan, period, okay? So if you have a radiologist who does a scan, you will learn about the radiology today. You can see here, that is a picture of the abdomen, and there is a black ball in the middle of it. See it? That is not normal. Every single radiologist will tell you that's not normal. What that means, though, is that the blood test that correlates with it may not be able to tell you how big it is. Here's another one. Look how beautiful these CT scans are, right? You can see in the middle there, you see those beautiful blood vessels right in the middle, the white ones, right? They're fantastic. See that little tiny little ball stuck right in the middle of it, right in the branch point of the delta right there? That is a tumor. Again, the radiologist may not be able to tell you exactly what it is, but they can tell you something is wrong. The blood test will probably not tell you how big it is. Right? So ultimately, the scans are still the most important thing that you have to have. Very, very, very rarely do I make a clinical decision purely based on a blood test. Okay. Now, this is a DOTA scan, which you've seen before, right? You don't need to be a radiologist to see what that means, right? This is one of the first gallium dotatate scans ever performed in this country. And when you compared it to Octrea scan, it gave you nothing. This is the test that told you. Again, the blood test is probably never, ever going to tell you exactly what you want to know compared to this test. So it's all relative. It's all relative. So, okay, now what does this mean for you all right? As I, keep drawing bloods, and I still do it, because I was told, what does it mean to me? Okay, first of all, how you feel is the most important, period, okay? I always tell people there are two things we try very hard to do. One is to improve your quality of life, right? And then two is to improve your quantity of life. Because if I told you, you are going to live 30 years with this slow-growing cancer, but you're going to be going to the bathroom 25 times a day, you may be like, I'm not sure I want to stick around all 30 years, right? I mean, you know what I mean, right? So that's number one. Anyone know what the second issue is? That's right. How you feel is the most important thing. Number two, all right? Anyone know what the third most important thing is? That's right, how you feel. That is good. And I know there are multiple people in this room who I've done surgery on, multiple people, and who have felt much better after their surgery, because it helps. Right? So how you feel is going to be the most important thing. So when you tell me, Eric, I don't feel well, I'm still having a lot of bowel movements, I'm losing weight, or whatever the issue is, then that's what I have to think about. It doesn't matter what the blood test shows me, right? Okay, so now that we know that's the most important thing, and the second and the third, then the thing I want you to understand about the evaluation is that the scans are the most important. The scans will tell me the size, the scans will tell me the distribution, the scans will tell me how much they've grown. The scans don't vary from place to place to place. CT scan is almost universally normalized across the United States. The scans are so good, and the radiologists are so good at reading CT scans that it's almost the same everywhere you go. Is it perfect? No, of course not. But it's almost uniform. And then don't forget, no one ever died of an elevated chromagranin, okay? I can take chromagranin, inject it into your body, and you would never know that anything happened, right? So no one ever died of that. Might it reflect something? Possibly. But the lab value itself is not actually what's dangerous, right? Just as Dr. Anthony said, if the gastrin is 20,000, the best thing to do is just to stop measuring it. I agree with that totally. Now, let me tell you the labs that are important, right? I do want to know how your vital organs are working. I want to know how your blood counts are, right? So that when I give you that PRRT, I'm not going to destroy your bone marrow, or that temozolomide, right? I want to know what your bilirubin level is, because most of the time when people are really in the end stage of neuroendocrine, a lot of them die of liver failure. And when they can't process bilirubin, that's a very dangerous and late sign for liver failure. I want to know how your kidneys are, because if I give you too much PRRT, I might ding your kidneys, right? It's not so bad anymore, obviously, but it's still very important. And of course, nutrition, right? There are people in this room who I know very well who have struggled with nutrition. They can't eat, their stomach is hurting all the time, and they're just losing weight, and they end up dying from malnutrition. So I want to know how your vital organs are and what your nutritional status is. Those are super important labs. Okay, so one more time. A few little pearls. Just understand the chromagranin and the various tests that you have can be very timing dependent, right? If you get your blood drawn close to your shot, maybe the shot is more suppressive of your hormone. If you get it always consistently at the end, that may be a little bit better and cleaner as far as interpreting it. But remember, the shot itself is not perfectly consistent either, right? So remember that. The lab that tests the blood that you sent off can change from place to place to place. So mine may be different from Kentucky, which may be different from St. Louis, and you'll get different values. And so you don't get confused by that. The medicines that you take may affect the markers as well, right? So we talk about Prilosec and Protonix and Nexium and omeprazole and those things. That will affect the labs. And unfortunately, the marker may or may not correlate with the scan. Many times we've had people who just tell me I'm not feeling so great and the hormones are maybe going up, but in fact the scans don't show anything really changed. So the tumors themselves have not really grown, but maybe they're more active in secreting more things. So sure, it can certainly torture you, and you may not feel so well, but the size of the tumor may not be so threatening that it starts to eat away at your liver, or block your bowels, or do something horrible that we'll show you this afternoon. So always remember that those things may not perfectly correlate, all right? And these labs are just one piece of information, right? I know, I'm a surgeon, but I still fancy myself a doctor, right? And when I'm a doctor, my job is to help you heal, help you feel better, help you live your life better, right? So those are the things that I try to do. And I always ask myself, is this lab really here to drive you crazy, or is it here to give you peace of mind? And a lot of it has to do with who you are. It's not really me. I have had many people come into my office with like these big fancy Excel spreadsheets. And I'm like, thank you very much. I think I pretend to look at it so they think I'm reading it, and then I put it down, right? So a lot of it has to do, what do you do, okay? So it depends on who you are, right? If you're an engineer, by all means, document it, write it down. So if you want to, go ahead and track the marker numbers, right? You put a date down, write down the things. It's helpful for me. I'm not gonna lie to you. It is actually more uniform if I can see it in one place, right? But you should probably also track your tumors, right? So if the CT scan says that a tumor is 1.1, then 1.2, then 3.5, that's a big deal, okay? Kind of depending on the time span. You should track your symptoms too, right? Number one is your well-being, right? So how do you feel? Oh my goodness, my tumors have grown. I started to have more flushing. I started to have more diarrhea. I'm having a more difficult time controlling my symptoms. And you can do all those things, right? The other option, and you should track the results of your treatments too. So for example, if you have PRRT, or you have an embolization, or you start your CAP-10 and these things start to improve or get worse, you should track those things down. Now the other option, which you certainly can do, is you can do none of those things. You can do none of those things and just kind of let us follow it and figure things out. So it depends on your personality, depends on what you want to do, how much you want to control it, because the things that you can control are one thing, how you live your life, right? My job is for you to be able to live your life as well as best you can. And if those things are important to you, then they're important to me, and the rest of it is just stuff that we have to figure out to get you there. I hope that makes sense, all right? Well, that's it. That's all the slides I have on biomarkers, because I clearly don't think too much of biomarkers. But I thank you for your attention, and I hope the day is valuable to you. That's it, right? Do we have Q&A now?